We're going to begin with Mr. Pialoux's presentation. I'm Dr. Basset. I'm the chair of the association called Addiction France. And we're going to have our last plenary session that will be dealing with dual disorders. Past, present, and future children. We have Professor Pialoux, who is an infectiologist, and he attended the same roundtable last time. So did I. So we will be able to look back on what we said last year during our roundtable. And then Nicolas, Hoertel, who is a psychiatrist at Paris Centre, will make an interesting and original presentation. But I will let you simply discover what he'll have to say.
La communication de Monsieur Pialoux.
So can we show Mr. Pialoux's slides?
Donc effectivement, je suis infectiologue.
Hello, I'm an infectiologist. I also deal with addictions as a collateral effect. I'm also in charge of a journal called Swaps, and I can see that many of you have grabbed a copy. Thank you. There won't be too much overlap between both presentations, which is a good thing. These are my disclosures. And I work for several groups, two think tanks, Terra Nova, the other one on COVID called Covidia. No financial links here. There's the publication I just mentioned earlier. I think there are some residents here. Don't forget that when you start such a presentation, you have to quote a very famous person. I debated between Nelson Mandela and Gandhi, so people will remember this and they will not remember what you said. So I chose a quote, and I chose to quote Amin Ben Yamina. I wanted to find a powerful quote, and I found his book on addictions and comorbidities. I like the word co-occurrence, which is difficult to pronounce, but it really reminds us of one comorbidity can be hiding behind another comorbidity, and this is what we are learning with this fifth wave.
Donc cette diapo, j'avais déjà montré.
I already showed this slide last time. It's not my slide. We had forecasted some waves, but they would be associated with the COVID wave. But we have COVID waves plus the associated waves. And this was published in 2020. And it really shows quite clearly that you have COVID, the impact on the resources, on the healthcare offerings, and addiction, cancer, HIV, psychiatry. Everyone was impacted, all patients were impacted, not just because some interventions had to be postponed, but also it was difficult to access care, and we have lost some time, and it will be difficult to catch up on all that time. Also, treatments that were interrupted, and fifth wave, which is the economic crisis, social crisis, burnout of some professionals, but health professionals, but not only.
Première question, est-ce que les troubles de psy sont des facteurs
de risque? Psychological disorders risk factors for COVID? I believe my colleague will come back to this. The short answer would be yes, it can be direct or indirect co-factors. We already touched upon this back in September 2020. When we got the first data, and we saw quite clearly that having a psychiatric disease in the multivariate analysis, because you need to remove specific constant factors, obesity, diabetes, precariousness, poverty, age also, we're talking about geriatric patients, but psychiatric disorders rapidly appeared as a risk factor. And when we prepared this session, all three of us, I remembered the room that we had built, a room with 13 beds, so beds that were closed because of lack of personnel. And I saw psychiatric patients, so often quite old. And I was wondering about the additional risks, and then we understood this because we had more data. So this is what was shown by Marion Leboyer last year. I've updated the data, and I have updated it, as I said. So what can we say? Patients who have a pre-existing psychiatric condition would have with the same behavior, the same risk as the general population of being affected by COVID. But this is more of a politically correct statement. A patient who is disabled with difficulties moving will not behave like people in the general population. Then they have high risk of having a serious form of COVID. And this situation for psychiatric patients, it has nothing to do with the comorbidity factors, no age, diabetes, etc. They might not even be sent to the ICU, and there might be a form of triage here. And there was also all the aggravating comorbidities.
Alors, il y a suffisamment d'études pour que des méta-analyses sortent, et cette méta-analyse est assez récente.
We have a recent meta-analysis here in Lancet Psychiatry 2021, 841 studies, they kept up to 33, and you have over 1.5 million patients with COVID, of whom 43,000, almost 44,000 had mental disorders, and the actual risk is 2.24 with a confidence interval between 1.7 and 2.94. So if we have a look at the detailed figures, anxiety disorders, anxiety disorders do not appear as being additional risk factors. Drug consumption or substance use disorders have a 1.676 odds ratio, intellectual disabilities 1.71, mood disorders 1.99, and psychotic disorders 2, national risk of 2 in this meta-analysis, which was done quite well, really.
Probablement l'étude la plus
this is
sur la psy, donc je dis pourquoi on la montre, mais c'est vraiment l'étude qui a été
the study that
en population générale. Et d'ailleurs,
was the one that was based on in the general population. Only the Brits and the Danish do studies in the general population because they have databases to do so. They can also cross ethnicity, socioeconomic data, and other data. So this is on 17 million British individuals. Approximately 17,000.
17 millions, pardon.
So 17 million were included.
Un nombre de 10 000 décès.
And 10,000
c'est dommage parce qu'ils n'ont pas un niveau de finesse qui permet de montrer, j'ai mis en rouge, qui pourrait se rapporter.
The data is not so precise enough, but for example, you don't have addictions, but it gives you an idea of the weight of each marker. And obesity ranks number 3. It's almost as important as the age, and you have diabetes. Comes out a lot, and all the malignant pathologies, obviously, and they have a dementia and a stroke with a natural risk of 2. In France, we have some data from EPIFAR, that is the French authority and French Social Security group.
Lié au Covid en milieu hospitalier à partir
These are the deaths in hospital.
En fonction
they use a traditional model based on age.
Là aussi, on a,
and here again, as you can see, you have psychotic disorders, dementia, mental retardation. In the beginning, at first, genetic pathologies, trisomy, etc., really came out as extremely high risk factors, and they were prioritized the vaccination efforts because the additional risk is of 4. So we also have French data. So, second question now.
suis en train de regarder dans quel sens marche le compteur.
Have they been talking for the past 15 minutes already?
D'accord. J'ai accéléré. Alors, le Covid comme impact péjoratif.
So, COVID as a negative impact on the mental health of the French people. This is something we read in the newspapers on a daily basis. We have a robust data with Santé publique France, and this is the COVID-PREV survey. It talks about the impact of COVID-19 on the mental health of the French population. So, at the top, you have the satisfaction score of the French. This is data from November 2021. So 79% of the French consider themselves as being satisfied with their current life, which is quite okay. But if I look at the second line, those are sleep disorders, they have increased, and paradoxically, they are not only aligned with the periods of lockdown, with the exception of the first lockdown period, so plus 17 points compared with the baseline year 2019, the year without COVID, so plus 17. Anxiety also, depression, red and purple, plus 9, plus 7, and there is also suicidal thoughts during the past 12 months, so plus 5 points. Even we are still below 10%, so plus 5 points compared with 2019. So addictions and harm reduction.
Partant de Covid, on en avait un peu discuté l'année dernière, effectivement, à la table ronde.
During the COVID pandemic, we talked about this at the roundtable last time. We have lots of data. This is the data from the CDC, overdoses during the COVID crisis. And you know this better than I do. There is an overlap with the opioid crisis in the US. And if we look at the increase in the dark brown, increase in extraction of psychostimulants, so cocaine, synthesized opioids. Generally speaking, in 50 states, you see you have an increase in the overdoses associated with those products. So, what about how come the restriction measures to the COVID haven't had a positive impact on the consumption of opioids? As you can see, it has actually made things even worse.
Donc ça, c'est une autre donnée du CDC.
This is other data from the CDC that was shown at the Liver Diseases Convention with overdoses before and after COVID.
Alors en France, on a
in France,
on est toujours avec le
we are still with EPIFA.
Ces données qui concernent les premières et deuxièmes vagues.
Data relates to the first and the second wave.
De la consommation de médicaments par l'assurance maladie.
The drug consumption. It's from the social security system, so it's quite reliable. What is what people buy, it's not what they actually consume, but plus 1.1 million treatments over the first 6 months. People might also have stocked up.
Des années précédentes. Les TSO, aussi probablement parce qu'on le voit surtout dans la semaine 12-13 de 2020, on a une augmentation et probablement un effet stockage parce que ça se retrouve 17,000 prescriptions and nicotinic
substitutes. Well, the prescriptions have decreased, although people are smoking more. This is a paper that talks about addictions during COVID. This is a French analysis that was done, had to do with the increased number of overdoses. Change in consumption patterns, and this is due to the fact that it's more difficult to have access to the products either via a dealer. So everything that's easier to access is being consumed more, and we are thinking about synthetic drugs that can be sent per mail, per regular mail. So what about tobacco? It's difficult to spread the word, but we all have to agree on this. In this meta-analysis that hasn't been peer-reviewed yet, I believe, to the left, if you look at the fact that you were an active smoker, the probability of being COVID positive tends to be a form of a protection if you were a smoker. But if you were a former smoker, so you have the hospital admissions in the middle and severe COVID to the right. And in this case, having being a smoker actually increases the risk of having severe COVID. And some addiction federations and some addictologists have already raised the alarm, saying that really you shouldn't say that nicotine is protecting people against COVID. Obviously, I don't need to convince you, but we shouldn't count on this protective effect of nicotine. What about addictions in France? Well, we have data from OFDT. This is for cannabis. We talked about tobacco early on. We're not going to review all those substances, but there is a global increase during lockdown of the daily consumption, a decrease for the occasional users, occasional consumers, and increase concerns 31% of the people during lockdown, according to FDT data. And this is for the first lockdown in France. Now, at European level, ODT is also working on the issue. They look into new synthetic drugs, and they are included in several data. Prevenir will include chemsex and synthetic drugs. I know there are some presentations during the symposium on those specific issues, and some molecules are being consumed more, and it seems that there's a shift towards substances that are supposedly easier to consume at home, and the more regular users are the ones who have increased their consumption levels, whereas occasional consumers have actually been stopped, prevented from consuming as often as they would have liked to. In this study done by a team in Antwerp, but we have the same study in London, it hasn't reduced sexual contacts, it hasn't reduced the related with unprotected sex, and chemsex seems to have still taken place. And people simply organized things differently, but they found ways to still do it. Several associations launched prevention campaigns, especially AID, that really decided to ask people to make sure that they would test for HIV and other sexually transmittable diseases using a TROD test after lockdown. There is another aspect that is more connex rather than dual. It's the impact on screening. I believe that the poor populations, some drug users or psychiatric patients are not going to be screened as much as in the past now for HIV and other diseases also. Now, thinking about HCV, this is also being impacted now, minus 66% for HIV in men, minus 49% in women. between February and April 2020. So this is one of the impacts of COVID on access to healthcare services. We will have to try and catch up on the time lost, as oncologists are doing, as epidemiologists are doing also. If you are an addictologist or infectiologist, it's important to go and get those people and make sure that they are screened and receive treatment. There is another type of addiction that is not always in the media. It's addiction to sex and sex on the internet, such as pornography. This is a study done by psychiatry this year. So the consumption of a peak increase in traffic on Pornhub. As you can see, very sharp, spectacular increases in some countries such as India, 95% increase.
Alors, après, j'irai pas jusqu'à faire trop de pub pour Swabs, mais on a fait
I don't want to advertise too much for Swabs, but we tried to look at what was going on in France and the respective regions. We tried to check how the centers got organized. And this is available online for free. We tried to ask how they adapted to the situation, especially during lockdowns.
Dans quelle voie se sont organisées ces différentes structures de prise en charge des usagers de drogue et de réduction des risques.
So we're talking about drug users and harm reduction approaches, and it was complicated, especially during the lockdowns.
Alors j'ai piqué une diapo là, vous allez dire que je faille.
I stole the slide from Laurent and Amin Benyamina, and I believe it summarizes many things. I don't agree with everything. Nonetheless, I think we should look at other substances, not just tobacco and alcohol. Even though French authority data regarding alcohol consumption is not as alarming as in other countries, for example, the UK.
Et bien sûr, la question du comportement.
Behaviors also. This is why I showed a slide on addiction to sex. This was probably negatively impacted by COVID.
Avec tout ce que ça comporte d'addiction
smartphone addiction to internet pornography.
Un certain nombre de populations, et pas seulement les HSH, pour des consommations de drogue qui sont finalement en libre accès sur le net.
Because those are things that are easily available on the internet. So I'm done my presentation. I always like this slide to conclude the presentation. I'm in charge of a COVID ward, and we're still hoping for the end of the game, and hopefully it will come sooner rather than later. Thank you very much.
Merci beaucoup.
Thank you. We decided to have the Q&A after both presentations, so we'll hand over the floor to Nicolas Hoertel, who is a psychiatrist at Paris Centre.
Merci beaucoup.
Thank you.
Je suis vraiment ravi et très touché de.
I'm very pleased to be here today. We have two complementary presentations, I would say.
Ne sauve leur pas, qui pourraient comme ça de prime
And
abord.
as you will see, you might believe that they are contradictory, but we'll try and find the links between both presentations.
Alors peut-être un mot, c'est l'ensemble des données que je vais vous présenter.
All the data that I will present to you today
d'une collaboration scientifique qui court maintenant depuis le début de l'épidémie et qui implique de nombreuses universités.
Were gathered thanks to
les principaux acteurs,
a collaboration between various stakeholders, German universities, Spanish universities, French CNRs, and IPBS
de Toulouse.
in Toulouse.
Alors, pardon, je vous présente mes liens d'intérêt.
So those are my disclosures.
Alors, première question, est-ce que vous avez entendu parler de
first question.
la fluvoxamine
Have you heard of fluvoxamine or fluoxetine as a possible treatment that would cure COVID?
Est-ce que ça vous dit quelque chose?
Does it ring a bell?
Alors là, je vous prends trois unes
Let
de journaux.
me
Les trois
show
comme les trois
three headlines in the most prestigious journals, Science, Scientific American, and Nature. As you can see, Fluoroxamine for coronavirus. Nature's title was Investigating Antidepressants' Surprising Effect on COVID Death and Common Antidepressant Slashes COVID Risks.
Alors, je vous apprends rien. Effectivement, la COVID, on est dans un contexte
COVID, as you know, is still there. We're still in the midst of a pandemic.
La recherche toujours très active de traitements.
And our researchers are still looking for efficient treatments.
Depuis le début de l'épidémie,
since the beginning of the epidemic,
rembobiner l'histoire par rapport à ces
let's say,
il s'est trouvé que moi je travaille
remember what happened. I work at the Corentin-Selton Hospital, and we are specialized in geriatric psychiatry. This is one of the only departments in France that does this. We have patients who are 85 years old on average, and since the beginning of the epidemic, we've only had 4 cases of severe COVID-19 infections. And people were very surprised by this. How come that our patients who are seems extremely vulnerable are not being severely ill? And this is also an observation made by our colleagues in New York. You know that they were greatly impacted by the pandemic. And one of my colleagues in New York was telling me that they were overwhelmed with patients, but their patients were not sent, were not hospitalized. And then there were psychiatric COVID-19 wards that had been set up in order to have multidisciplinary teams with psychiatrists, pneumologists, infectiologists, in order to attend to psychiatric patients with COVID. We had those units in certain number of hospitals during the first wave, and the occupancy rates were quite low, and they didn't reopen during the following waves.
Alors, finalement, cette observation, c'est une observation empirique.
And this is empirical information for severe cases. We know that a majority of people have a severe COVID. So, can we really verify this?
Eh bien, ce qu'on a fait, c'est qu'on a regardé les données sur l'ensemble de la PHP.
We have studied the data from HPHP.
Et on a utilisé les données de l'entrepôt de données de santé.
39 hospitals, and we had looked at the data. During the first 3 waves,
il y a eu un total de près de 50 000 patients.
Almost 50,000 patients were hospitalized for COVID with a positive PCR test. And we started looking at the frequency of psychiatric disorders. So primary disorders, depression, schizophrenia, anxiety. 3.4%, and this is extremely interesting. So this was the prevalence of those primary psychiatric disorders. And you have the meta-analysis that Professor Pialoux mentioned with 1 million patients. So 1 million patients, in that meta-analysis, only 40,000 patients had a psychiatric disorder. That's 4%. So you're going to ask whether this is a high percentage or not. So now, if you have a epidemiological study, what kind of a prevalence would you expect regarding psychiatric disorders? What is the prevalence in the general population? And often they are overrepresented in hospitals, so the expected number would be between 10 and 20%. And the meta-analysis that was presented in our data give the same figure. Less than 4% of the patients have psychiatric disorder. So 4% of the patients hospitalized for COVID have a psychiatric disorder. In practice, 4% psychiatric disorders, so secondary disorders, so confusion or neurocognitive disorder. So confusion is part of the psychiatric disorders, but you know and we know that it can be secondary to other pathologies. In our study, we tried to see whether those rare patients who had a psychiatric disorder had HPAP, whether there was a link with the mortality risk. What we found was that, as in the meta-analysis, we have more or less the same numbers. If we only adjust for age and sex, which was the case in the published meta-analysis, we have additional risk for those few patients who are hospitalized. And now, if you include medical comorbidities, we know that age is a most important factor. Number two, age again, and number three, associated medical pathologies. If we take into account all those pathologies, we see that those patients die less than what we might expect based on their age and their pathology. At HPHP, those patients tend to have 12 comorbidities compared with the general population of people hospitalized for COVID. So people who have extremely high risk factors of having a severe form of the disease. This was confirmed by a German study, was published also, and this study carried out a multivariate analysis that looked for the various risk factors, mortality at 6 months in patients hospitalized for COVID, and c'est-à-dire une mortalité divisée par 2 assimilée le fait d'avoir une dépression. Was divided by 2 for people with depression. And you might find this surprising because you wouldn't expect a psychiatric pathology to have a protective effect on COVID. So in March 2020, we wondered about repositioning a few antidepressants in order to fight COVID.
Mais à savoir que déjà les antidépresseurs,
so antidepressants, as many of you know,
eh bien, c'est des médicaments repositionnés.
Are drugs that are already repositioned. The first antidepressant is iproniazid. It's a antibiotic against tuberculosis. We know that this is not sufficient to treat tuberculosis. We use 3 therapies now, but it seemed to improve mood, and it was offered to patients with depression, and this is how we came about with antidepressants. As we know, antidepressants have an anti-inflammatory effect that is well known. This is a meta-analysis.
Pardon, excusez-moi, je me bats un peu avec. Donc, une méta-analyse.
So this is a meta-analysis of the effect of antidepressants on inflammation. And what we find is that there is a significant decrease in the IL-6, IL-10, and 1 beta. And those markers are inflammatory markers associated with the severity of COVID. And we thought that maybe we could reposition those treatments, and maybe they could fight COVID thanks to their anti-inflammatory properties. In the literature, what was back in March 2020, we had 2 animal models for septic shock. First use fluoxetine, and second one used fluvoxamine. So what do both studies show? If you give fluoxetine or fluvoxamine to a mouse who has a septic shock, then mortality decreases. And this is due to the anti-inflammatory effect, and you have a reduction of TNF or interleukin 6.
Alors, finalement, les hypothèses autour de ces mécanismes anti-inflammatoires ne sont pas encore très bien connues.
This anti-inflammatory mechanism are not so well known. First, you have the sigma-1 receptor agonist effect,
associé à la fluvoxamine.
And this is associated with fluvoxamine.
Le degré d'effet
and you have the
antidépresseurs sur le
effect of antidepressants on sigma-1 receptor, and you would have the list of the drugs. Fluvoxamine would be better than fluoxetine, citalopram, etc.
Des phénomènes d'immunomodulation.
Then you have an immunomodulating effect and antioxidant effect.
Alors, suite à ces données, on s'est lancé donc dans une étude observationnelle.
We opened an observation study. We wanted to see whether in hospital, among the COVID patients, the fact to be under antidepressant is associated with possible reduction of the risk of intubation or risk of death. 7,233 patients, some of them were under antidepressant when at entry, and we found a effect on the risk of intubation. The risk was decreased by 50%. Then we look at the different compounds, and we observed a significant effect for 5 compounds: fluoxetine, citalopram, meloxicillin, mirtazapine, and venlafaxine. And the effect, we wondered about the effect. These 2 compounds has a sigma-1 effect, and the other 3 don't have any such sigma-1 effect. So at this stage, we couldn't possibly understand the mechanism. Since then, other published confirmed our results. The first one. First is a Spanish study. They found exactly the same association with the symptoms effect, observational study. Another one was carried out in Hungary on fluoxetine, which same effect, a reduction. And a large-scale study that was published some time ago, more than 80,000 patients in the US of A, which again found a reduction in the mortality when antidepressant and fluoxetine in particular. So what about the potential mechanism involved? In July 20, when we published our result online, we thought possibly antiviral effect, anti-inflammatory effect, but there were other molecular pathways that could account for this anti-inflammatory effect. And this is where, after the publishing of the results, our team got in touch with the 2 professors, Professor Goldmans and Professor Kornfuller, and both told us the 5 antidepressants significantly associated with the reduced mortality or intubation, while all of them functional inhibitor of sphingomyelase acid, ASM. I never heard about this mechanism. Very briefly, this is a sketch. Now, this is an enzyme which is found in the lysosome, the inner wall. When the cell is stimulated, lysosome will fuse, merge with the membrane. The enzyme is found in the cellular membrane and accounts for the conversion of the sphingolin into ceramide. Ceramides group receptors at the surface of the cell may amplify an intracellular signal. So they went a bit further. They tested to see whether this could have anything to do with antidepressant. First of all, they looked at in vitro. They observed that with the virus, there is activation of this enzyme within 30 minutes, and then they could verify that a number of antidepressants, which are inhibitors of sphingomyelase, have an in vitro antiviral effect, significant effect. And they went even one step further, and they were able to show that by adding ceramides, that is this lipid which is made by the enzyme, they could restore the infection. And they went even further and recruited healthy volunteers. They sampled nasal epithelial cells, put in contact with the virus in vitro, and observed an infection. And then they gave 1 tablet of antidepressant, Fiasma, that inhibits the enzyme. And 2 hours later, they sampled again the nasal epithelial cells, put them in vitro, and found no sign of infection. 24 later, they found a new sign of infection, which means that it requires a second tablet. Now, what are the best Fiasmas in vitro? You have the order. The first one is amitriptyline, tricycle. You reject this because we know that it's not well authoritative in elderly people. The second one in fluoxetine, then paroxetine, then fluvoxamine, and then citalopram. Interesting to see that if you inhibit this enzyme strongly in vitro, well, the antiviral effect will be stronger against SARS-CoV-2. Specifically on fluoxetine, which was selected, as it were, as potentially best treatment, fiasma treatment amongst antidepressants, we tested a number of cell models, including pulmonary epithelium in human, where you find a significant reduction of the viral load after fluoxetine. And this is a virus specific to SARS-CoV-2, but not for other viruses, like rabies of HIV or HIV. You know, these in vitro models have their limits, so you have to rely on in vivo data. So Dr. Céline Cougo, you see her photograph here. She started the animal model, very kindly allowed me to give a presentation of her data, and of course for scientific review. Peer review. Now here, you wanted to treat JAKs vivo, transgenic mice that express receptor SARS-CoV-2, and some mice are infecting, others saline, and the others group fluoxetine. So what about the dosage? When we have a problem for animal models, an animal is not a human, it might be pharmacokinetic differences between molecules and compounds, especially for antidepressant. Well, the mice is more developed than men. When an antidepressant treatment may remain for a few days in a human man, but not in mice, because degradation happens very fast. If you calculate the exact dose that you need to inhibit the enzyme in the lung, it's 40 milligrams per kilo. What about the outcome of this experiment? At day 2 and day 6, we're showing the mice, you see a reduction of the pulmonary viral load in excess of 90%. Then we also observe that temperature of the mouse is better if you treat with the fluoxetine. Maybe you're not aware of it. It's exactly the contrary in mice. Septic shock mice becomes frozen. When we have infection, it's how temperature goes up. It's the opposite in mice. So the habitual temperature of mice is 30 degrees. So their temperature went below about 34 degrees for treated mice. And then we could observe anti-inflammatory effect with a significant reduction of interleukin-6, CFS2, and another one. So we wanted to know whether these two antiviral inflammatory effects were independent of one another, and we see that in fluoxetine mice, there's no relation between the quantity of virus detected and the expression of interleukin-6, which suggests that the antiviral and anti-inflammatory effects are independent of one another. Fluoxetine was detected on the number of variants, Delta, the Brazilian variant as well, and every time you see the same degree of efficacy in terms of reduction of viral load in vitro, and there's some different types of cells as well. So we wanted to make sure, because if indeed the drugs, antidepressants that have this fiasma effect, you expect a fiasma antidepressant to reduce the risk of mortality with intubation, and this wouldn't be the case for the other ones. We've tested this with our data, and we found that indeed patients who were given a fiasma antidepressant had a risk of death and intubation that was divided by a factor 2 compared with those who were under a depressant without the effect. So you see the univariate model, just observation, the percentage, and multivariate model, you get the same results because the population is very similar in terms of characteristics, features. So conclusion, we know that all these data tell us that acid physiomyelinase-ceramide system is central, plays a central role in the COVID-19 infection. If this is the case, we have a biomarker. Meaning that if it's central in a person who is infected by COVID, where I expect to see an increased activity of ASR, especially increase in the rate of the ceramide in blood. And this is the case. Ceramide in blood is highly correlated to the clinical with the particular diagnosis. Some patients have symptoms and won't go to hospital, while others will end up in the emergency department. And it's also predictive of the viral load. What about clinical trials? As you know, the maximum degree to assess the efficacy of treatment are clinical trials. Clinical trials were carried out in the USA, and they selected why fluvoxamine? Because at some point you said that fluvoxamine is only the third chiasma among ISSS. So this is Dr. Angela Riasson. She's a psychopediatrist, and she had the same idea. It occurred to her that fluvoxamine would be relevant. She was reading Rosen's paper showing that in an animal model in Sheptopsy, fluvoxamine reduces the mortality because it has an anti-inflammatory effect. And she suggested to Professor Eric Vance, the right picture, to have a clinical test to test this hypothesis. And the problem there that you need money. If you want to do a clinical test, it's difficult to fund this kind of test in the absence of data. And that was, we say at the time, that our team was contacted at that time in this discussion. That's why we stepped in the discussion. Very straightforward. First of all, what about the sigma-1 mechanism? Fluvoxamine works better than fluoxetine. This is a fact. Well, let's test fluoxetine. But the sigma-1, if fluoxetine is better than sigma, it's not as good in terms of sigma-1. So half-life, plasma half-life, it's short. Fluoxetine is 1 to 4 days instead of 12 to 15. But there are pulmonary distribution data showing that fluoxetine, that Prozac, is a drug that is most concentrated in the lung. Pulmonary concentration of Prozac is 60 times higher than blood. Now, this is unknown. It's not the case for fluoxetine, so we know that fluoxetine is supposed to work even faster. We have observational data for fluoxetine, not fluoxetine, and the last one, very important, was production chains. You know, fluoxetine is 40 years of age. It's 40 years. So all the production chains, the system is, fluoxetine is in Europe. So after a heated discussion, we decided that our American colleagues would go for this fluvoxamine test. This gave occasion to publish in JAMA if they found that fluvoxamine given to outpatient basis is associated to less risk of clinical worsening at 15 days, double-blind, randomized test, and the clinical worsening, dyspnea or hospitalization for pneumonia and/or desaturation in oxygen lower than 90%. 0 patients were degraded, as opposed to 6. That's 8.3% in the placebo. So 6 versus 0 is not that different, but the independent committee thought that it was not ethical to continue the trial in view of the difference. The second trial was an open-ended trial. COVID patients with a symptom were asked whether they would accept fluvoxamine. Those who said yes were given, and the other was not. And then we compared the two groups, and we found 0% hospitalization in fluvoxamine as opposed to 12%, 6% in the traditional care. And they looked at residual symptoms at 14 days, 0 patients in fluvoxamine as opposed to 60% who had symptoms when taken care of by usual drug. And that's when the Together trial started, multi-arm trial to test different repositioned treatments that was funded by Gates, the Gates Foundation. So Professor Edward Mills organized this trial. He started in April 2020 and was conducted in Brazil, tested a number of repositioned molecule. As soon as we knew that the molecule was not efficient, you would not move to the next one. Hydroxychloroquine was tested, not efficient. Metformin, same thing. Metformin, etc. And one molecule was found to be effective, fluvoxamine. So the fluvoxamine trial included in excess of 1,000 patients, 700 in placebo group, and the results were as follows. The first one, a composite criterion. They wanted to see whether the reduction of the risk of hospitalization was enough or prolonged surveillance in the emergency department. Now, the trial was rolled out in Brazil. They have a different health system. There was a limited number of hospitals there, and they started to install tents in the poorer parts of the city for screening or case finding. Were properly equipped and were able to treat patients in favelas. And this is where we went for this composite criteria, prolonged surveillance that more than 6 hours are being the main outcome. Fluvoxamine was associated to a reduction of 30% to go to hospital, according to this composite criteria. Very interesting to see, to look at the per protocol. What is the per protocol criteria endpoint? You see, if you accept to be in the trial, you're given something. You don't know whether it's a tablet. You don't know whether it's a placebo, a real drug. 30% of people, when they take the drug at home, don't take it or stop taking tablets as early as possible. So we looked at those patients who had taken the drug to the end and the looked at the effect, and they found 67% decrease in the risk to go to a hospital in terms of mortality, 81% of the risk to die among those people who had taken either the placebo or the drug consistently. The last trial published in a very severe population. That's a paper in the emergency ward, resuscitation. It's an open-ended test. They took patients who required intubation or ventilation and gave a high dose fluvoxamine for 2 weeks. And then they did a match study for each patient who was on fluvoxamine. And they found another patient, same sex, same age, same severity of infection, same comorbidity factors, and they found that fluvoxamine was significantly associated to a 42 reduction of the on the risk to die, even taken at a late stage. Okay, so we have so much for the evidence. What are we going to do next? In our group, there are American actors for clinical trials. There are German experts on biology, French people. So we gave this to a number of bodies, the NNH, that started 2 trials on fluvoxamine, and they are currently writing their guidelines as to the current level of evidence of fluvoxamine. ACTA2, we show them our data, and same thing to DDNA, Joint for Drugs for Neglected Diseases Initiative, which is the armed arm of the USA. And there's an anti-curve arm, Rule 16, and WHO. They started a systematic review of literature to assess that treatment. Conclusion: is it possible to reposition fluvoxamine or fluoxetine? This is the whole difference between scientific evidence and scientific and presumption in sciences. And this might be counterintuitive, even beyond the level of evidence per se. You want to be able to have a consensus, to see a consensus. And this is the difference between truth, facts, and believing. Guidelines are based on a belief. Typically, that would be influenced by a scientific level of evidence. Now, at this stage, we have a number of hospital observation studies for antidepressants. Fluoxetine is one of them. Preclinical data in vitro and vivo for fluoxetine, and data for 4 clinical trials, 2 randomized versus placebo, and for fluoxamine. Now, mechanism of action, potential mechanism of action, antiviral effect, and anti-inflammatory. No need to remind you the advantages of repositioning. We've been constantly repositioning. We have a 40 years experience of molecules given to individuals. We know exactly the risk that we're taking, and you know these risks are very modest, very low. Accessible price is good enough, low enough. Availability, fluoxetine is on the list of the WHO essential drugs. In other words, a state pharmacist said that they have to have this drug. Or it's given orally. It doesn't seem to be sensitive to variants. It's non-mutagenic, so no risk to create new variants. So interesting to see the method of repositioning. As you could see, sometimes you wonder whether it's ethical to start a clinical trial with a very low level of evidence. In this particular case, the fact that we had observational studies, because it's already used in a number of patients that match preclinical data, is very good, because we ask a patient whether we want to include in a clinical trial. You can tell them, I'm very familiar with the drug, I know exactly what your risks are, and second, I have substantial scientific evidence, arguments to say that it is efficient or effective. To conclude, we refer a lot to the stigma attached. I'm still continuing on this adventure. The vision one can have on the psychiatric patient, they're extremely valuable. They contribute a lot of information. Sometimes they're perceived as vulnerable patient, but in fact, psychiatric patients tell us that yes, this treatment is recommended as a curative treatment in the months to come. It's already given in many countries, US, Brazil, Asia. It's been given for months. If these guidelines become official, then we'll be able to say that this is thanks to our patients, thanks to the observational information we will collect from them. Thank you. Thank you for this stimulating intervention and speech. I'm sure there want to be questions in the room. Not questions for journalists. Are we supposed to store Prozac, etc.? Who would like to ask a question to either Nicolas Hoertel or Gilles Pialoux? I can't see very clearly whether any hands is raised. Do you have a microphone, Amine? Thank you, Gilles. Thank you, Nicolas. I'd like to pick up on your presentation very briefly, and then Gilles will take over. On patients who had on fluvoxamine, I imagine there's a prevalence of infection. Did you see less infections or fewer or better protection in these patients retrospectively? Literature? Was it found? Thank you. Well, in this particular point, I don't have any data, but it's very tempting. We'd like to look at this. I think it seemed to be so counterintuitive that I haven't seen many studies, even on other topics, on viruses like the flu. On German data, in vitro, you see there's a specificity for certain viruses where DNDi, because we work with them, they've already launched the studies for Ebola. They found exactly the same results at preclinical stage. A brief comment, if I may. Very interesting, fascinating, I would say. Well, the history of therapeutic clinical trials for COVID, I'm sorry I finished with Hout, nothing to do with the Didier Hout story, apart from the repositioning, which is really bright. It's very good that you got this idea. I did see the publications in high-level reviews. How to moderate our enthusiasm. I'm kind of a tourist in this. I think that the animal model, I'm not a specialist in animal model, but the mouse, of course, is not the best animal model, even for SARS-CoV-2. Even if you graft the gene for ACE receptor 2, but that's a detail. And then you showed, you could have shown so many other trials for repositioning of molecules, compounds. I remember on COVID, it was incredible. Well, antiretrovirals were on the list of those compounds. There were 200 compounds that are effective in vitro in different models, and that includes the Syrian hamster, which is probably the best animal model. And then together in your study, all the compounds that you tested, all of them, Pinavir, anti-HIV, anti-malarial drugs, anti-HCC, and they're efficient in vitro, but they didn't make it beyond the clinical side. So there's an enigma. I'm not sure what the end of the story will be, maybe for next year. The most complicated part is that there are direct antiviral drugs, polymerase inhibitors that act directly, polymerase by Merck company, protease inhibitor by Pfizer. So, and of course, this is bound to bias, if you like, your trial, because they're going to be used for comparison purposes. So it's not going to make your life any easier. That was actually in passing. You spent a lot of energy publishing to achieve this repositioning, and this is a sound, right approach. A question on fluoxetine and fluoxamine. Is it used in parallel with the high-dose corticoids? Thank you. I stand to be corrected by my colleague, Professor Pialoux. Now, we are special in Europe. We cannot prescribe off-label, and it's very strict. So I'm not supposed to tell you that you have to push prescription. There are scientific societies that do that, and this is what it's good to be scientific. You have to have a high enough level of evidence. If it's true, the demonstration has to be absolutely valid, and then the recommendation will be made. You'll have such a guideline. In the US, you can do off-label when on the basis of clinical trials, reliable clinical trials. You may prescribe this treatment to a patient who accepts to be given this treatment. Now, many doctors do prescribe it. In the US, it's recommended by many professors of infectiology, David Boulay being one of them. Same thing in India, in Brazil, and they tell about their experience. They have a rebound effect at day 5. This is kind of a discussion you can have between doctors. But in France, it's not possible. You can't prescribe this drug at this stage as long as no official agency recommends it. The last point, it's very interesting to see that the objective, the aim we pursued, because we're living at a time where treatments were not really discussed. They were talking about vaccination. But we realize that you have patients in hospitals, a few individuals only. Unfortunately, it's only few people, but with the severe forms. And then you have those who say no. So the treatment is very important. It's not in opposition. It has to be combined. It can be associated. So treating is a very good thing. We are all very happy to see that there are more and more treatments. And then you need to assess the efficacy of these drugs, and one single disaster study is not enough. We have a number of examples in the past showing that it was extremely disappointing. There was an industrial study, but it proved not to be the right path. Antiviral is supposed to have potential strong effects to begin with at the very beginning of the disease, and not so much after some time. So you have to make sure that the mechanism of action are okay, and also to assess compounds and molecules at different stages of severity. It was an open-label test. It's good. So we will have to organize more structured clinical trials, and maybe it will open new pathways, or, and this is the case in a number of arms, a supranational association between one fiasma antidepressant or the Pfizer treatment or anti-VR treatment. The question was also on research. All the have controlled arm in all trials, and the gold standard of care is included there. So we treat the anti-monoclonal drugs. So you cannot prevent the case that the anti-monoclonal will be used, because it's a part of the standard of care. If you engineer a survey test now, of course, dexamethasone will be possible, even anti-monoclonal drugs, because they're included in the French guidelines. So you can set aside something which is supposed to be the gold standard. Dexamethasone is only for severe forms. So we used to use it on an outpatient basis in a number of countries, but it's something which is rather deleterious as far as we can see. And this accounted for the fact that ivermectin was thought to be useful. And then we realized that the data, ivermectin were 2 fraudulent trials that were scrapped, but it's been more effective in poor countries compared with European countries, and probably because it's reduce or limits the excess mortality due to the presence of parasites. Other questions?
Hello. Maybe I'm going too fast, but I'd be interested to know what you're expecting regarding the use of fluoxetine in this framework. It's quite exciting, and we could take recommendations. You could take it how many days after the symptoms appear? Are there data about it or not?
Évidemment, encore une fois, je prends la précaution de vous dire que...
Well, I'll take precautions to say that there's no official recommendation to use this drug in France.
Voilà. Par contre, en tout cas, les 3 essais...
So the 3 outpatient trials do that on the same window. So treatment, the trials included patients COVID plus with symptoms, with at least one comorbidity in general. So they were stratified with an extra risk of severe forms, and they had been symptomatic for less than 7 days. That's at least the window we've got, what's reasonable, because we know that there's always lag. And that's the criticism in some other trials. As you know, usually we're all like that. If you catch COVID, you don't feel as well. At first, you're in denial. You think that it's going to go away. Then you get tested. You need to wait for the results. And then you'll motivate yourself to go and see a doctor. So a bit of time goes by, and you realize that usually people go to their doctor after a few days. So one of the main methodological biases in a COVID trial is to consider that it's feasible for patients to receive treatment on day 1 or 2 of the beginning of the infection, and that doesn't fit the epidemiological data about the time frame that you see in real life. That's what's in the data. Another question? Well, I think that we can thank both Gilles Pialoux and Nicolas Hoertel for participating in this session. A very interesting one.